All right. I am flying solo for this one. Christine will join me in the musculoskeletal system diseases. So we let's get started. This is usually the point where I say, hello, Christine, good to see you. And she tells me how smart and hardworking of a partner I am for her. And she thanks me for doing all the hard work. So we'll pretend we did that. So musculoskeletal system injuries, there's our learning objectives as always. The tissues that we are talking about with the musculoskeletal system: bone, ligaments, joints, the musculotendinous unit, that's where the muscle turns into the tendon, and then that tendon is going to go attached to the bone. And then bursas are something that we underestimate, I think, a lot in physical therapy and occupational therapy. We'll expand on that. So all of what we're talking about are connective tissue. So what's the purpose of the connective tissue? Well, we're going to support structures, bind, keep them together, protect, improve alignment, attachment, and facilitates movement of adjacent structures. That's really what I think of when I think of the musculoskeletal system and the connective tissue. So all of those things that we're talking about: cartilage, joint capsules, ligaments, tendons, bursa, they are all connective tissues. Intervertebral discs, bone, meniscus, skin, fascia, those are all connective tissues as well. Now, what the makeup of each connective tissue is going to help determine what its exact function is. So the makeup of bone is different than tendon, different than ligament, different than muscle, different than fascia. And it's just the balance of materials that's in each one is going to give it specific function. So what are the components of connective tissue? Well, cells. All right, great. But that cellular mix is specific to each structure. So the fibers that those cells are going to produce, they're either going to be elastin, collagen are the two big ones that I always think of, and the reticular fibers as well. So again, all the same components of it, but the mix is different. The balance of which one is it. So some tissues that are more flexible are going to have more elastin in it. Tissues that are more rigid are going to have more collagen in it. Cells are named according to the structures, such as fibrocytes, osteocytes are for bone, chondrocytes are for cartilage. And there are three types of fibers. Collagen fibers are strong and have high degree of tensile strength. That means they don't stretch very much and they can withstand a great amount of force. Those are more rope-like structures as well, where elastin fibers are much more flexible. And when those structures become elongated, they can recoil back to its original length. And then the reticular fibers attach all of these other structures together. In the intracellular matrix, we have a bunch of fluid, ground substance, and other proteins. Don't really need to remember all of it, but it is very important because that's where a lot of the nutrients get into these fibers, different tissues. So we have different types of connective tissue. We have loose irregular, which has equal amount of collagen and elastin fibers to it. There, when you look at loose irregular, it looks almost like a cobweb. Lots of different patterns, and there looks to be little rhyme or reason to it. Superficial fascia is a great example of this. Not very dense. The fibers are a little bit all over the place. Dense irregular now has less elastin and more collagen, so it is a stronger fiber. Examples of this are deep fascia and scar tissue are examples of dense irregular. Again, the pattern of these irregular connective tissue is a little scattered. They're a little bit all over the place, almost like that cobweb type look to it. Now, Regular connective tissue has more collagen than elastin. The fibers are more dense. The exact density will vary depending on the exact structure. This is used to attach muscles to bones, stabilize joints, or facilitate movement. So types of these regular connective tissue, of course, tendon, ligament, joint capsules. Those are the big three examples of that. Other tissue structures that further modify all of those types: fat, scar, bone, cartilage. And one law of the human body that I want to highlight is Wolff's Law. Wolff's Law says the body will adapt to the amount of force and direction placed upon it. So that's why our bones are shaped the way they are. Why do we have a big tibial tuberosity? Well, that's where we get our patella tendon attachment site to. So that pulls on the bone and we create a little lump there. So when we are rehabbing somebody with some of these connective tissue issues and injuries, we want to place stress on them in order to get it close to its original shape and fiber direction. So if we're going to be doing a massage to a scar, well, we're going to try to break up the density, but we're going to do it in a variety of angles because we want that cobweb type shape, where if we only massage it in one direction, it would be flexible in one direction and rigid in another. So that's why it's important to understand the different types of connective tissue and their general appearance. Some bone anatomy to quickly review. The periosteum is a highly vascular outer covering of the bone. So that's the most superficial layer of it. It's where the bone gets all of its nutrients from. Vascular, that vascular tissue is going to drive blood flow into it. Then we have the endosteum, the inner layer of the bone, sitting up on that cancellous or spongy bone. We have compact. Let me try to blow that up a little bit. I think that'll help you a little bit. So there's our periosteum, then our endosteum, and you can see the spongy bone throughout. Compact bone is the hard bone that sits between the periosteum and the endosteum. Trabeculae not shown in this picture, but they are the lines of fibers that the bones to provide additional strength. And then we have the cancellous or the spongy bone. The spongy part contains bone marrow, which is red inside the spaces. And when we get into osteoporosis, we'll see how the spongy bone is going to be a really easy picture for that. And then the diaphysis is the long shaft, the shaft of the long bones. The medullary cavity is the inner core of the long bone, contains yellow fatty marrow. And if in the surgical world, to fix a fracture, sometimes you have to put a rod right through it. That's called an intermedullary rod, right through the medullary cavity. And then we have the epiphyseal plates. Those are the growth plates that sit on the ends of the long bones. That would be, here's the epiphyseal plate right there. Another one right up here. If those epiphyseal plates become hardened and they close up, that's how we can take an x-ray to determine if someone's growing or not. So the structure of bone, the collagen stiffened by calcium and phosphate. So now we have an extremely rigid structure that helps with its weight-bearing capabilities. The ground substance is mineralized, the higher cell density. It is vascular, and with immobilization, what's going to happen is the bone will begin to lose substance to it if it's prolonged immobilization. I'm talking years. So that would create a bone density problem. So bone density can decrease at 10 to 15 days. And at 12 weeks, density can be 50 to 60% of its normal density. So if we compound that over years, we can really impact the density of this tissue, this bone tissue. And now it's going to be really tough to perform weight bearing exercises in a safe manner. So next I want to go into some fractures. I added musculoskeletal images. So that's going to help us with some of these fractures. So we have green stick fractures, which a fracture is a broken bone. So a fracture is a broken bone, usually caused by excessive forces. But sometimes we can have other pathologies impacting it, bone cancer, osteoporosis, that could also impact it. So the first one we want to talk about is a green stick fracture. That's one right here. So these occur only in kids because kids' bones are way more flexible. They have a lot more elastic fibers to it. So what happens is that there is force here that breaks this side, but this other side bends. So the convex side bends, the concave side cracks. We have hairline fractures, which we don't have a picture of on this one, but those are where there's a fracture into the tissue itself, but the ends of the bones, those two pieces, they don't actually separate. Simple fractures are complete fractures that result in two fracture segments. Here's a transverse fracture that would be a good picture of that. Compound fractures are also known as open fractures. And these are really bad because now a piece of the bone punctures the skin. We know from our integumentary lecture that the second the skin is compromised, now we have an extreme risk for infection. Also, the vascular disruption of the bone itself can be very, very problematic to recover from. Comminuted fractures are also known as crush fractures. So there's multiple segments to it, more than two. Usually crush injury, car accident, something like that. Really terrible. Impacted fractures where one bone is forced into another one. So if I, went to the basketball court and I dunked it, windmill, jamorama, and then I dropped down with my legs stacked on top of one another, you could tell how the tibia and femur would just compact and impacted fracture would result from that. We also have a spiral fracture where there's a twisting force in the bone, and that would create a spiral fracture. The most common mechanism I see of this is baseball pitchers, creating so much torque that they fracture their own humerus. And then we have depressed fractures. Really, I've only seen this in the skull where the bone gets pushed inward. So I have some other pictures of it. So you can see here's this green stick fracture, broken on one side of it, bent on the other. Hairline, we can't even see. Here's that spiral fracture. You can see them trying to indicate that torquing motion. Here's comminuted, mangled mess, and there's our depressed fracture. I think this was a Muay Thai fighter. He's having a rough day. Hey, maybe you won. We don't know. So some complications can arise. Obviously, if we go back to that depressed fracture in the skull, high risk for brain injury as a complication of that. With the femur, vascular damage can happen, not only of the vasculature outside of the bone, but also especially into the bone. So if we fracture towards the head of the femur, then we could get avascular necrosis where we've disrupted the blood supply. Now the bone can't get its own nutrients, and then the head of the femur starts dying off. So that can happen. Fractures with the spine can result in paralysis because the spine is meant to create that shell around the spinal cord, and if we disrupt that, if we disrupt the spinal cord, we can get paralysis. We'll talk about neurology next week. And then ribs and pelvis fractures can result in visceral damage. Rib fractures, I think of lung damage all the time. That's the first thing we want to rule out. So what happens to heal a bone fracture? So first it must be reduced. That means the ends are brought together. So if I have an end way over here and an end here, they're not going to connect to one another. So first they need to be reduced. If surgery is not required, it's called a closed reduction. Again, open versus closed in this sense refers to the skin. If the skin is intact, if the skin remains intact, closed. If they have to do surgery to get the two ends of bones together, then now that's an open reduction. Now, if they have to put in hardware to fix the two ends of bones, so, okay, hey, grab the two ends of bones, then throw some plates and screws and wires or whatever else they might need to use. So that is then called open reduction internal fixation. So then they had to fixate it. So the external fixation is the cast. The internal fixation, rods, pins, things like that. So the abbreviation of that is ORIF. Very, very common in the rehab world to see a bunch of ORIFs. So what happens is once the fragment hematoma forms and there's reabsorption of the fragment ends within the first 2 days, with the first 24 hours. In the first 2 days, the osteoblasts come in. So osteoblasts build. Osteoclasts, CLASTS, help resorb the bone tissue. So in the first 24 hours, osteoclasts, then osteoblasts begin to build. In the first 24 hours, because we are taking the ends of the bones, the ends of the fractures, if we were to take an x-ray right after a fracture, sometimes it's tough to tell. If we waited 24 hours, because the osteoclasts are taking in those fragment ends, it's going to be much more pronounced after 24 hours than at hour 1. So sometimes that's why if you have a patient get an x-ray immediately after an injury and they say, no, nothing's broken here. And then a couple of days later, they say, this still hurts. I can't put weight on this. They take another x-ray. They say, oh, no, it's clearly broken. That's why that sometimes happens. So at about 2 days, osteoblasts begin to build more bone, producing osteocytes, and the osteocytes start piling up to form a callus. A callus is just a big pile of osteocytes, big bone cells. That's noticeable at somewhere between 5 and 8 weeks that we can start seeing that. Different ages and different bones have different healing times, just generally because of the blood flow that's available to it. So that looks like a big ball, a big lump. So body kind of overproduces all of these things. So just send a bunch of bone, get all these things back together. And then the osteoclasts come in and start to resorb some of that material and further calcify the callus. And then we can have some full healing after that. So there's always this balance between osteoclasts and osteoblasts. Now that callus is pretty soft initially. So depending on the age of the patient and the type of fracture and where the fracture is, this is the reason why we can have partial weight bearing for some of our patients at this point, because yes, the two ends of the bone are there, but that callus is soft. We're going to put this person on a partial weight bearing status until this fracture fully heals at somewhere between 6 and 12 weeks, depending on age, fracture severity, and patient specifics. So a couple of types of joints that we want to talk about: synarthrosis joints. So those easy ones are the suture type joints like in our skulls, or I wish Christine was here for this, the gomphosis, which are peg-like joints. That's what our teeth are. So the synarthrosis joints don't move. The amphithrosis have slightly movable joints. So a good example of this is the pubic symphysis. And the diarthrodial joints is now a movable joint. The diarthrodial joints are synovial joints. So sometimes we call them diarthrodial, sometimes we call them synovial. Those words are interchangeable. So the reason why they're synovial joints is because one, it's movable, two, it has a joint capsule, and three, it has synovial fluid in the joint. So all the joints in our spine extremities, most of them are synovial or diarthrodial joints, and the amount of movement of each of them just depends on the shape of the joint itself. So there's our classic synovial joint, joint capsule, which envelops the entire joint, gives some extra protection. On the outside, there could also be some extra capsular ligament, like the collateral ligaments. Inside of the area is the joint cavity, which houses synovium, synovial fluid, meniscus, if there is some, articular cartilage, and some ligaments. So the intercapsular cruciate ligaments, ACL and PCL of the knee, are examples of this. Synovial membrane is inside the joint capsule, and it produces synovial fluid, which produces fluid that lubricates and provides nutrients to the joint structures, to the joint tissues. And when somebody has range of motion precautions, so after a rotator cuff repair, for instance, they can't, for the first few weeks, can't move their shoulder at all. One of the reasons why passive range of motion and gentle joint mobilizations for those people is really crucial, is because we get to produce more synovial fluid from this. Synovial fluid is produced with movement, weight bearing, also rhythmic moving back and forth can all help produce synovial fluid, which is only going to help the joint nutrition. We also have articular cartilage, which is the shiny end caps of these joints. White shiny material like Teflon coating, very, very slick substances, helps with the joint movement. And when that cartilage breaks down, that's the beginning stage of osteoarthritis. That's destruction of that articular cartilage. Happens primarily in weight-bearing joints, knees, hips, ankle, and spine. It is a progressive disorder. We used to say that it happens in hardworking men. That means labor workers, construction workers, things like that, and overweight women. That was the classic description of osteoarthritis. Not exactly true anymore. A lot more people get it than just those two groups, but that's definitely the old term for it. Classic description of symptoms is pain and stiffness in the morning, which resolves after some movement, but then after prolonged activity, that pain can increase again. Heating modalities are typically helpful. That helps increase the synovial fluid production. We can also decrease forces, decrease abnormal forces, either improve alignment or decrease some weight. So if we lost weight, we'd have less force on our weight-bearing joints, therefore less pain. Always medication, non-steroidal anti-inflammatories are common, or we could replace the whole joint. We'll dive into OA just a little bit more down the road. So some other joint tissues. The function of ligaments is to stabilize the joint by protecting it from excessive movement. So it's very, very strong in the direction that it would resist, but it will allow normal movement, the movement that joint is supposed to. So it's that those ligaments are made of dense, regular connective tissue that connect the two bones together. Cartilage is specialized tissue with hyaline, elastic, and fibrosis tissue to it. Hyaline cartilage is found on some joint surfaces like costal cartilages. Elastic cartilage is springy, like in the ear. And the fibrocartilage has more collagen for movement and weight-bearing forces, just like intervertebral discs menisci, and in the AC joint. So those are 3 different types of cartilage. So some injuries that can happen to these ligaments, well, we call ligament sprains, SPRAINS. We can have a mild first degree, which means there are very few fibers of this ligament that are disrupted. That's a first degree. Moderate second degree, where there is some tearing of the ligament. And then severe is third degree, where there is a rupture of that ligament or even an avulsion. That means the whole piece of bone that it was attached to, that bone is now pulled away, known as an avulsion fracture. So grade 1, a few fibers torn, some bleeding into the ligament, mild inflammation, no functional loss. When testing the ligament in a stress test, does this ligament hold up still? Yes, it does. So to treat it, we would just protect the joint and treat those symptoms, those swelling symptoms, until they resolve. In a grade 2 sprain, we would have all of those signs and symptoms of the first degree, although now there would also be some functional loss of ligament. So as we test it, there'd be more joint play. We could also get an MRI, MRA, where injected dye is into the area. So for these, we can have an option, surgery or not surgery. Usually we can help improve and optimize healing to avoid progressing the injury. We might have some splints, bracing, or casts. Again, signs and symptoms are managed. Pain and swelling symptoms are managed. Once that ligament is healed, then we could help strengthen the exercises and return to function after that. And then grade 3 will need some sort of surgical procedure, and then we would be able to rehab them, physical therapy and occupational therapy after. Subluxation or dislocation injuries. Dislocation is entire separation of a joint. Subluxation is a mild, caused by excessive force in a specific direction. So in the shoulder, it's abducted to 90, externally rotated to 90 with force can dislocate my shoulder anteriorly. Again, that subluxation is only a partial displacement. Dislocation is fully displaced. So we would need to, as we're rehabbing, we would need to avoid the motion that reproduces that injury. So as we're rehabbing, we would avoid that until we're stable to do so. Big damage that can happen to it is we could damage those neurovascular structures. So easy to think of in the shoulder, I have my brachial plexus and brachial arteries right in the anterior side. So if I dislocated the head of my humerus in that direction, we could really disrupt those. And that can have great consequences for me going forward. So could require surgery. And it can reoccur. So that's one of the reasons why surgery to reinforce the ligaments and joint capsule can help. Herniated intervertebral disc, very, very common injury. All of us are going to experience with our patients at some point. So these intervertebral discs are in between the vertebral bodies, help with some cushioning, help provide some nutrients. So the center of the disc, I have a picture of it. Let's see. So the center of this intervertebral disc is the annulus, is the nucleus. So the nucleus has a lot of water to it, and it allows great motion. The annular fibers, the annulus pulposus, are these what we see in this view as rings around that. So those are the more rigid structures to that disc. So the other terms for herniated intervertebral disc, herniated nucleus pulposus actually talks about this nucleus actually moving and coming out. Disc protrusion is another one. There are some risk factors for it. It could be wear and tear over time, could be genetic predisposition. Other risk factors include age, obesity, trauma, and genetics. The trauma is an interesting one. The most common one is lifting something really heavy. And a lot of times, if somebody complains of, oh, I heard a big pop, I heard that's these annular fibers tearing. If disc material then protrudes and invades the spinal cavity, either the neuroforamen or the central cavity, usually just one side or the other, then now we're going to create a bunch of the neurological problems. So because we're compressing that nerve root. So the treatment includes reducing the risk factors like losing weight, anti-inflammatory medication, and pain medication can be used. Physical therapy, occupational therapy, massage might help relieve muscle spasm, improve the mechanics of the spine. And then also occupational therapy can further help modify the activities that create some of the problems. Bursitis is very, very common. The bursa is a synovial structure. So there are bursas all over in the body. They are near any place that the body needs to reduce friction. So over any joint, any place where there's a high pressure area, underneath of the patella tendon is a big one. So these bursas help lubricate, help provide a slick surface so they can rub back and forth without a lot of friction. So what can happen is once these bursas become inflamed, they can grow, and grow is a terrible term for it because they're just fluid filling, but they can expand up to 11 times its original size. Most common place that this is a problem for both OT and PT is the subacromial bursitis. That's the number one most common bursitis that we see in the PT world. I think I have a picture of that as well. Yeah, good. So you can see just how many are in the knee itself: suprapatellar, prepatellar, infrapatellar, subaortal, atorial. But here's this subacromial bursa right here. So you can see how if this thing grows 11 times its original size, when this person tries to lift up their humerus, all of this tissue is going to become compressed and cause that pain. Treatment for bursitis would be our RICE, rest ice compression elevation. Could be with some medication as well. And sometimes we'll need some sort of padding to reduce the tension or impact on that bursa itself. A couple of different muscles that we want to talk about, then we'll talk about injuries to them. The skeletal muscles are voluntary muscles. I have to want to contract them to do it. Cardiac and smooth we'll look at in later on the cardiopulm lectures. We'll look at those types of it. So the musculotendinous unit. So first we have the tenoperistal junction. That's where the tendon is attaching to the periosteum of the bone. Then it goes into the tendon. Then the musculotendinous junction, where there's the in-between fibers of tendon and muscle. Then we have muscle belly, and then all the same thing attaching to the other end of the muscle. Nope, did not get a picture of that one. So what is the function of the muscle? It's connective tissue. The muscle fibers, it's contractile. So we can, with the functional unit of the muscle is a sarcomere, where actin filaments and myosin filaments slide apart and together when it's either elongating or contracting. High elastin fiber content and loosely organized allows for that contraction and stretching as well. Where the muscle attaches to the nerve, because the nerve is going to send a signal to the muscle on when to contract. That's called the myoneural junction. And in that, we have also mechanical receptors embedded in the muscle tissue. A couple of those receptors are one, muscle spindles. They're going to respond to the stretch of a muscle. So if that's actually the reflex. So if you get your patella tendon hit, it's going to create this contractile reaction to it. Why? Because we are deforming the patella tendon, which the body thinks of it as a stretch, and the body doesn't really think, it's just reacting. So it reacts to it as a stretch. The muscle spindles within that tendon becomes elongated, sends a signal to the nerves and spines, and then we get a protective contraction. Another mechanical receptor is the Golgi tendon organ, Golgi tendon organ. GTOs is what they're abbreviated by. And that responds to how much pressure is in a muscle. So how come we can grab a heavy box that Amazon left on our front step? We pick it up. We don't know what's in it. How come we don't just say pick it up and it throws up to the sky? Well, because our Golgi tendon organs regulate how much tension the muscle is under and help us coordinate how much pressure to exert based on what those Golgi tendon organs tell us to do. So what do muscles do when they are immobilized? Well, first, they adaptively shorten. So if we were to be in a cast with my elbow flexed, my biceps will now become adaptively shortened. So that means they lose that functional unit of the muscle as sarcomeres. And now that length has now become shortened. This can also happen over time with poor posture. So if I had really poor posture and really rounded shoulders, now my pec muscles are going to become adaptively shortened because of that. Stretch weakness is when a muscle is in a lengthened position, but it doesn't return to its original length. So it's stuck in a stretch. So that muscle has become incredibly elongated, and now we're going to be reducing power as well. The mechanical receptor activity decreases as well. And the connective tissue will weaken if the ground substance is not circulating. So that ground substance, again, all of that fluid that's helping circulate nutrients doesn't circulate. Now the tissue has less nutrients as well. And that's a big reason why we increase the risk of muscle strains as we age, the amount of dehydration and the decreased ground substance available in our muscles. So muscles now strain, strain, sprains for ligaments, strain for muscles. Our first degree is few fibers are disrupted, same definition. Second degree, some tearing at the musculotendinous unit, again, partial tearing. Second degree, similar to our ligamentous sprains. And third degree is an avulsion or rupture. So now the whole thing is separated. Either the tendon itself is ripped through or it pulled the bone off and we have that avulsion fracture. So a grade 1, no real loss of motion or strength, some inflammation, pain, muscle spasms. So we treat those corresponding symptoms. Grade 2 could need protection for about 4 to 6 weeks. Activities are restricted to avoid making the tear worse, and then we control the inflammation signs and the pain as well. Once it heals, then we can restore all of the other good things that we need to: muscle length, muscle strength. And then a severe or grade 3 is going to need some sort of surgery to help suture the structures together. And the last injury we'll talk about for now is carpal tunnel syndrome. So this is where we have a sprain to the transverse ligament, either from overuse or prolonged poor positioning. The problem with that is we can entrap that median nerve that sits underneath of it. Right there, you can see. So either from the edema or just that compression itself from the poor positioning. Middle-aged women are affected more often than men. And we can treat with either splinting, massage, stretching, ergonomics education, medication to reduce inflammation, and sometimes surgery to relieve that pressure is needed as well. So that was the last thing we wanted to talk about for today. Christine's going to join me and we'll talk about musculoskeletal system diseases next. So I hope you guys enjoyed my solo trip, and we'll have Christine next. We'll talk soon.